This 3-week-old baby boy was born at 39+6 via vaginal delivery. He presented healthy vital signs, but the parents reported that he had some regular hiccups and difficulty with burping after feeds. He rarely had regurgitations, but occasional posseting with a little bit of milk coming out of his mouth. In the perinatal history, the uterine contractions started irregularly a couple of days before the birth. Here you see the transition from the global assessment, making the first contact with the baby, making eye contact and physical contact, to a more detailed and specific examination routine with primitive reflexes and all the osteopathic movement. You look at quality, you look at quantity of movement, and the general tone and elasticities of tissues. As we undress the baby, have a look at the skin. Are there any rashes, any birthmarks, any sign of bruising? And you can look at the folds around the inguinal area, the gluteal folds. The baby is slightly hungry here, so just take a few moments to pause over the abdomen and the diaphragm to try to settle him before I can continue. With the spinal assessment, you get a sense of rotation and side bending patterns throughout the body, whether the baby is held into a bit of a banana shape or rotatory component. And we move to the head to assess sutures and fontanelles. The presence of the mother will help reassure him. Holding hands, looking for the palmar reflex, see how he resists, he maintains his flexion at the elbows, which is a good sign of tone, and then the head lag, which is present all the way up to 3 to 4 months. Tiger in the tree is a great way for the baby to appreciate your contact, feel a little more secure in your arms, and with my right hand I have a full contact over the abdomen with the viscera hanging in my hands, and I can have a feel for any tension, resistance, densities. Primitive reflexes may include spinal gallant, palmar grasp, plantar reflex, Babinski, stepping and placing reflexes. You may choose few to assess for presence of the reflexes, whether they are appropriate for age, and if they are symmetrical. Cranial assessment will examine any densities around sutures and fontanelles that may be a sign of craniosynostosis, bulging, or excessive compressions, and any malformations of the cranium that may point out to a plagiocephaly, a brachycephaly, a scaphocephaly. In ventral and dorsal suspensions, you have a sense of the general body tone and observe the spontaneous movement and the flexion at the limbs. So we observe here the normal flexion at the elbows and knees. Slight flexion and extension at the pelvis and hips is used here to see whether the abdomen allows me to stretch a little bit into extension and whether the hips and pelvis are stuck into that initial fetal flexure state. Neck movement in rotation and side bending allows us to detect any asymmetries, any restrictions that might be due to torticollis or a more global myofascial chain tension due to a plagiocephaly, or maybe a clubfoot or congenital talipes equinovarus pulling in on one side and maintaining the neck, head, maybe dorsals in one position. With intraoral assessment, you look for the initial rooting followed by sucking reflex. You check whether the tongue can hold on to the thumb or to the little finger, how strong the hold the latch is, and whether you can see a normal and vital, dynamic, active sucking movement of the jaw, of the pharynx, of the hyoid muscles. Spend a little bit of time around the tongue to see whether it forms a proper cupping movement around your little finger, whether the tongue seems to be held on by perhaps an anterior frenulum, causing therefore tongue tie or ankyloglossia, or whether you feel that the tongue is free to move and perform a good sucking movement. We smoothly move into the treatment and try to appreciate the positions in which the baby will start to relax, feel supported, start to express the mechanisms of tensions that may be present in his body. I am connecting with the body rhythm within the baby to appreciate the primary respiratory mechanism, to appreciate the oscillations, the body rhythm that supports the health mechanism within his body, within his tissues, and to let him guide me towards a point of neutral, of comfort for him, when and where the osteopathic treatment will start to emerge. We begin with a position for him of relative extension and progress slightly towards a state of flexion, as if he's returning into that fetal stage, in fetal compression within the uterine environment, when he might have been compressed excessively, particularly during the last 48 hours prior to birth, when the contractions began irregularly and then, of course, increased in intensity prior to labor. The exploration leads me more and more towards his diaphragm, the abdomen that seems to be sucked in, pulled in, as if the fetal position, the flexion, is held in the diaphragm. And here we can start to apply the principle of balanced ligamentous or balanced membranous tension, into finding the ease and working around that point of ease and neutral to allow the body to recognize, acknowledge, and work with the primary respiratory mechanism to unfold, to release that flexion, that compression that seems to be held into the diaphragm. Here I am supporting him more and more into that fetal position, and his whole body seems to relax. Maybe he's being reminded of that position he held for a period of time, but perhaps with a sense of peace and tranquility. And so his body is learning to appreciate that. So remember, you move from the still point to a sense of adjustment, reorganization, remodeling in a balanced ligamentous tension terms. And once you felt that still point, then accompany the baby towards that release, and you'll know that your technique and maybe treatment is over.